Welcome to Community Health Matters. I'm your host, Kristen Presall. On our show today, when an injury or illness strikes, how do you make the decision to go to a walk-in clinic or the emergency room? Jason Boylan joins us from the Third and Church Healthcare Clinic to talk about how to know where to go to get the appropriate level of care. Becca Morris joins us from the Metro Nashville Health Department to talk about the prevalence of smoking here in Tennessee and how to kick the habit. And Dr. Michael Warren with the Tennessee Department of Health will discuss infant mortality and the importance of safe sleep practices for babies. All of that coming up next on Community Health Matters. Did you know approximately 14 to 27% of all emergency room visits could take place at an urgent care center or retail clinic? That's according to a 2010 study in the publication Health Affairs. For non-emergency care, retail clinics and urgent care centers can be more convenient and affordable. So when your doctor's office is closed and you need non-emergency care, a walk-in clinic may be able to quickly provide the care you need. We'd like to welcome Jason Boylan, who is the founder of Third and Church Healthcare. Thanks so much for being with us, Jason.
Thanks for having me.
Tell us a little bit about Third and Church, if you will, please.
Third and Church Healthcare is an urgent care walk-in clinic downtown Nashville, right in the core of downtown. We're open for the public to walk in for different illnesses and injuries. We take care of people.
A lot of people curious about urgent health care or places because they know the ER, they know their doctor, but at the same time, when do I go to visit a place like yours? And I've noticed a lot of these, as I'm sure a lot of people have, kind of popping up. Why do you think that is?
Well, demand is one. I mean, more people are getting on plans with Affordable Care Act, so people are trying to access health care. Oftentimes, they're not able to get in to see their primary care provider, so they need something and they need to have it that day or within a reasonable time frame. And oftentimes there's a wait list, several days, often weeks, to see your primary care person. So that fills a gap, especially when it comes to common illnesses and injuries.
Yeah, a great convenience factor. And obviously your establishment is located downtown. What type of services can you tell folks urgent care clinics usually provide?
Urgent care clinics in general, they take care of a lot of different illness and injuries, mostly common injuries and illnesses such as, upper respiratory infections, bronchitis, sinusitis, but also there's another level of care that people may not consider, such as laceration repair, minor fracture, stabilization, even just, urinary tract infections. These are, some things that you may not consider. They have full lab, often X-ray, and services that you would also find in a hospital setting. So.
Yeah, a lot of folks, I think, if they were to feel as though they broke a bone or something like that, the first thing they would do is probably go to an ER. And so you're saying, these facilities can actually take a look at the injury itself. Right.
Yeah. Facilities like mine and other urgent care clinics, almost all of them have urgent, X-ray equipment. So if there's a minor fracture that needs to be stabilized, and like if somebody came in, needed to be seen, we would take an X-ray, stabilize the injury, and get them connected to an orthopedist, much like you would be in an emergency room department.
That being said, tell us what kind of healthcare professionals you can find in an urgent care clinic.
Well, there's a team of professionals that take care of people. For instance, you'll have typically the provider will either be a nurse practitioner, physician assistant, or an MD. You'll have X-ray technicians, medical assistants, and other supportive care employees that help make the experience more efficient, quick, and quality.
Sure. When someone comes to see you and you feel they definitely need to go and see a specialist, or maybe they should be going on to the ER, what do you do in that situation?
Well, I've trained, in my particular facility, we've trained the staff to really recognize what is an emergent condition. So if somebody comes in and they're complaining of chest pain or acute shortness of breath or have had a major trauma, then we will initiate the 911 protocol and get them to the emergency room as soon as possible so they can have a good outcome with that. So, but you know, those are exceptions, and we're ready to take those on when they come in so that we can get them where they need to be.
Now, Jason, we should point out you actually had worked in an ER yourself as a nurse practitioner. So did you see some patients coming in to your facility at the time and thinking they could have used something like this instead?
Yeah, so you know, at the emergency department, there was multiple visits. You know, I wouldn't give it a statistic in my mind, but it just seemed like every day I was asking myself, you know, why didn't this person have access to another facility to take care of this non-emergent condition?
Sure.
And I think, you know, a lot of it is education about what urgent care centers can do, and you know, other walk-in clinics, and you know, that's just a, you know, but to answer your question, yes, there was multiple visits that came in that just were not emergent and could have been seen in an outpatient center.
Let's talk a little bit about cost too, because you said, you know, a lot of people, you know, signing up for insurance and with the Affordable Care Act and that kind of thing, more people have that kind of insurance. Obviously, urgent care centers do take that, you know, the insurance, but it's a good thing for patients, I assume, a lesser cost to them in the long run, yes?
Yeah, it's well documented how much emergency rooms cost versus an outpatient center. And with more and more costs being passed back to the consumer with higher deductibles and all that, it's, you know, it behooves the patient to really figure out what would be, you know, the appropriate place to visit for the appropriate cost. Now, you know, that's not that being said, you know, that doesn't mean you know, you're going to go to an emergency department or versus the urgent care. You're going to go to urgent care versus emergency department based on cost. If you have an emergency, you're going to the emergency room.
Absolutely.
But
yeah.
yes, cost is a big deal.
And obviously, so is convenience. You know, for a lot of these places that have popped up, you know, you're going to want to be able to go there. Maybe it's right down the street compared to a drive to a hospital or something like that, or your doctor's office. Would you say the convenience factor for these clinics, as well as cost, is, you know, probably the biggest benefits for the patient?
Absolutely. I mean, if you go to an emergency department, you know, they're going to take care of emergencies first. So you're going to be pushed to the back of the line, per se, and that can be a several-hour wait. You know, if you're in there for an upper respiratory issue or a urinary tract issue, something that could be treated outpatient, it is going to be a long wait, most likely. So yes, the urgent care centers, no doubt, will get you in and out quicker.
Yeah. When people, you know, who are watching this program or sitting at home, how do they decide if they can go to your facility? You know, if something happens, if there's a fall or if they're sick and they don't seem to be getting over it, what do they need to be asking themselves before they go to your clinic or a clinic like that as opposed to the ER?
Well, you know, there is a lot of information and misinformation, of course, out there. And, you know, I think it'd be nice if you had a medical home to call and you could ask the nurse there, and, you know, just to get some direction. Most people have you know, a primary care office that takes care of them, and they can call, and the nurse may direct them to the urgent care, or they may direct them to the emergency room, or they may try to work them in. That would be the #1 place I would call, is your primary care facility, so that they're familiar with your case and they can kind of direct you. You know, I would caution people to self-diagnose on the internet and different things that happen all the time.
I was going to say, in this day and age, I think people are so prone to go to that computer and kind of check it out and say, oh, maybe what do I have? You know, is this okay to go there? But
right.
But you're saying obviously calling your healthcare provider is #1.
That would be #1. Yeah, it can be. It's not cut and dry.
Sure.
There's a lot of gray areas in
Sure.
these conditions. So.
Absolutely. What do you recommend to people if they're unsure about a health complaint? You know, what to do as far as that's concerned?
Well, you know, with the increased amount of walk-in clinics, and you know, if you're unsure, then most likely you're going to want to get some reassurance.
Yes.
And so, you know, the really way to do that would be see a licensed professional to give you that.
Yeah, no matter a walk-in clinic, your doctor, whomever.
Correct.
All right. Well, Jason Boylan, thank you so much for your time today.
Yeah,
Great
thanks
information.
for having me. It's been fun.
Absolutely. Did you know quitting smoking before the age of 40 reduces the risk of dying from smoke-related disease by almost 90%? But whenever you quit, there are increasing benefits over time. Within weeks, your circulation improves and your lung function increases. In just months, coughing and shortness of breath decrease. And after 1 year, the risk of coronary disease is half that of a continuing smoker. These are just a few of the benefits of quitting smoking for good. For help quitting, call the Tennessee Tobacco Quit line at 1-800-QUIT-NOW. We would like to welcome to the program Becca Morris, who is with Metro's Health Department. And if you're somebody who has thought about quitting smoking, this is going to be a topic that you really want to listen to and pay close attention to, because Becca here is going to be talking all about that topic and the fact that smoking is prevalent here in Tennessee, right?
It is. Roughly 24% of Tennesseans smoke, which is well above the national average of 18%.
Yeah, I mean, it's been a consistent issue, although I will say, to a lot of credit for businesses and healthcare industry alike, you know, they seem to be doing a lot of things to try to curb it for a lot of folks.
Absolutely.
But it's difficult to quit.
Absolutely, and we're seeing a decline in smoking, but it's just not as significant as we would like for it to be. You know, as the Surgeon General said this past year, it's a winnable battle, and we believe that it's a winnable battle. It's just getting all the players on the team, and many of those players are those smokers that are out there that have had many failed attempts at quitting. So what can we do to help them?
Sure, and we're not just talking about smoking. I mean, obviously that's the first thing that comes to mind, but there's a lot of different kind of tobacco uses out there. I mean, we're talking dip, chew, snuff. So how many Tennesseans use these forms of tobacco?
Sure, and it's interesting because a lot of people don't think smokeless tobacco is harmful.
Sure.
You know, you don't smoke it, you don't swallow it, so
I'm not inhaling anything.
It can't hurt me, but that's, you know, that's not true, and we want more people to understand the harmful effects of chewed tobacco. Roughly 6% of Tennesseans use smokeless tobacco, and that's again above the national average of around 4%.
Okay, when we're talking about Tennesseans, again specifically,
Absolutely.
and we're going back to smoking, but tobacco of any kind, at what age do you all find, does it statistically say, that people begin to use these products?
Well, 70% of Americans across the board, Tennesseans alike, begin smoking before the age of 18. Most have their first cigarette at the age of 11, and many addicted by the age of 14.
Yeah. All right, so many people have tried to stop, you know, tried to quit. They're unsuccessful. It's one of those things, though, that I think that they try, they quit, and then all of a sudden, a couple weeks later, they're back at it. Do you find that there are enough programs out there nowadays and good ones that are making progress as far as that's concerned?
Absolutely.
To keep them from doing that?
Absolutely. Again, it's hard to be a quitter once you're addicted to cigarette smoke, but it doesn't mean that you can't make that reach, and you can reach that. There's multiple therapies that are out there, including medications that you can try, nicotine replacement therapies. There's over-the-counter, there's also prescriptive. There's also non-nicotine medications, and again, we encourage anyone to speak to their provider and talk to them about the best options for them. But there's also non-medication options, including counseling, just talking to your doctor. There's mobile apps that are getting a lot of rage right now, where they send you little messages saying, hey, you can do this, you've gone 30 minutes without a cigarette. So again, there's all kinds of really new, interesting, intriguing tools that are out there to help people succeed.
Yeah, to encourage them.
Absolutely.
Also, smoking cessation classes, those still exist. That's a great way for people to be able to sign up. Talk with other folks, obviously, that are kind of battling the same thing or facing the same challenge, I should say, in terms of wanting to do that. And are those helpful?
They are. We're seeing a trend away from the classes, more so. There's actually online classes that are actually occurring now where you can Skype with other people who are trying to quit. So again, we're trying to meet the technology so that people are comfortable in those ways. So, you know, although classes are incredibly successful and we encourage them and we still have them across the community, a lot of people are using more of the telephonic coaching as well as the mobile apps to help with that counseling piece. But what we do like to talk about is that oftentimes when you use the NRT mixed with the counseling, with having someone to talk to, you're going to be much more successful at that quit attempt. So using one, you could be successful, but partnering them together, you're going to be more successful in quitting.
Do you find also that people do better with groups? I mean, you know, whether it be something via Skype or if it's something, you know, more in a setting of just trying to reach out within your own company too. I mean, I know a lot of companies try to to have folks quit.
And we encourage it. You know, oftentimes, you know, you want to set a quit date. That's the most important part. But when you have people that are quitting with you, when you have a group, you know, at work, absolutely, support is number one in being successful in quitting.
Sure.
You shouldn't be shameful of trying to quit smoking. You should let the world know that you're trying to do it, and you're going to be much more successful.
So we don't necessarily see people smoking as much in public, I should say. I mean, like I mentioned earlier on, a lot of restaurants have said, you know, no more. I mean, that's been in existence for a long time.
Absolutely.
But anywhere, even, you know, any kind of place where you shopping malls, the whole thing, you don't necessarily see people doing that a whole lot anymore. People are smoking at home. The bad thing, though, is if kids are around. Talk a little bit about the disadvantages of having kids being, you know, exposed to smoke or tobacco products in general.
Well, I mean, secondhand smoke has over 7,000 chemicals in it. 100 of those toxic, 70 of those have been proven to cause cancer. Around children, it gets even worse with their delicate systems. So more ear infections, more severe asthma attacks, more ear infections, more respiratory illness, including sudden infant death syndrome. So again, we want to be very cognizant of children in the home. If you have children in your home, you shouldn't let anyone smoke in your home or near your home. You should have a smoke-free car. It's not okay. Rolling down the windows does not help alleviate the smoke. Make sure your daycares and your children's schools are smoke-free.
Oh, that's something, that's a great point to
Absolutely.
make.
And then also looking, you know, if someone in your home does smoke, you know, again, having them go outside obviously is first choice, but also you want to think about the fact when they do come inside, have them wash their hands, have them have a particular jacket that they put on to go outside and smoke in. They take that jacket off, and then the smoke particles are not on them as they're holding the infant. So those are just separate things that you want to think about that are definitely going to help alleviate the secondhand smoke issues.
That's so, it's so many good points to make as far as that's concerned. And we should also talk, when we're talking about babies and children, if you're wanting to start a family and you are a smoker, whether or not your dad or mom who's going to be carrying the baby, this is the time to do it.
Absolutely. You definitely want to think about quitting before you get pregnant, or you definitely do not want to be smoking while you're pregnant.
Yeah. All right.
Absolutely.
Let's go ahead and say you make that decision, you say, I want to quit. And as I mentioned already, a lot of people struggle. They go back and forth pretty easily. So where do you start? What's the first thing that you could tell folks, Becca, of this is the great place to start right here?
It's talk to your doctor. Talk to your doctor, have the conversation, find out what's going to be the best method for you to quit. You know, set the quit date. You know, we have the Great American Smokeout that exists here in the country, and it's a wonderful day. It's a great day where people actually put down the butts for a day, but we always try to tell people, well, that's a great day to set it and stick with it. So pick a date that means something to you. Is it Great American Smokeout? Is it your birthday? Is it your anniversary? Pick a date that matters and stick to it. Put it on the calendar, circle it. Decide whether or not you're going to use nicotine replacement therapy, and start. Keep trying. You may not be successful the first time. Again, like I think, you know, like I've said, it's sometimes 7 to 9 attempts before someone is successful. So keep trying.
Yeah, and setting that goal is so important. Like you said, picking a certain date, a special date, that's even better.
Yeah,
all right, one last thing I want to ask you as far as healthcare providers. You had mentioned some of the different things, the patches and whatnot. What else can they offer up folks who come to them and say, I'm ready to quit?
Resource, guidance. I mean, you really need to talk to your healthcare provider if you're thinking about quitting. They really are a key part of being successful in the process.
And they work with you, obviously, the whole time.
Absolutely.
If you are someone who faces that challenge of then falling off the wagon per se or whatever and saying, okay, I've got to go back, you can always pick back up that conversation, obviously, with them.
Yes, it's so important. Never forget that they're there for you, that the community's here for you, and we want you to be healthy.
Excellent. All right, Becca Morris with Metro Health Department, thank you so much for your time. This is such really good information.
Thank you for having me.
All right. Did you know approximately 1 in 5 pregnant women in Tennessee smokes during her pregnancy? If all pregnant women in the United States stopped smoking, there would be an estimated 11% reduction in stillbirths and a 5% reduction in newborn deaths. If you need help to stop smoking, talk with your doctor or check out the information available at smokefree.gov. We'd like to welcome to the program Dr. Michael Warren from the Tennessee Department of Health. So nice to visit with you today.
Thanks, you as well.
Let's talk about a definition, if you don't mind, just to start the conversation off. Tell everybody what infant mortality is.
So when we talk about infant mortality, we mean the death of a baby before that first year of life is complete. So from any time from birth on through day 364.
How are we doing as far as this is concerned as a state?
So I think it's important to note we're a lot better than we used to be. So we've made tremendous progress. We've reduced infant mortality by about 15% over the past 5 years in Tennessee. We're a long way from where we'd like to be. So on average, about 7 babies out of every 1,000 born in Tennessee die before reaching their first birthday. And if you translate that into real numbers, it's about 540 babies a year that die before reaching their first birthday. And that's higher than the national average. And we know in some populations, particularly African Americans, that number is even higher. So we've got a long way to go.
Yeah, I was going to ask you, where do we compare when we're talking national statistics and even internationally?
So we tend to be in the bottom 5 nationally. It's not a place we want to be. We'd like to be in the top 10. So we've got a long way to go there. And if you compare, if Tennessee were a country and you were to compare us with other countries in the world, we would rank with countries that you typically think about as being developing countries, not ones with very good health rankings overall. So a lot of opportunity for improvement.
All right. What are the risk factors, Dr. Warren, that contribute to this devastating outcome?
Well, we know in Tennessee that when babies are born premature or at low birth weight, those are the main drivers of infant mortality in our state. And we have a large number of babies that are born that way every year. So that's a big driver. But we also know that some things that happen after the delivery can have an impact as well. So about 20% of all our infant deaths are due to unsafe sleep practices. Things like bed sharing or putting a baby down to sleep on its stomach or with lots of blankets and things in the crib. So those are absolutely preventable deaths and right now contribute in a large way to our infant mortality rate.
Yeah, you know, I know, you know, a lot of women, when they first have a child, especially their first child, you know, that bonding time that you want with them, the co-sleeping as you were talking about, even wanting to get sleep when you're sleep deprived and maybe have baby sleep on their belly for the reasons that they may sleep better. But I know your strongest, you know, message is to say don't do that and keep them on their back. Sudden infant death syndrome, we've heard of it many times, SIDS. Explain a little bit more about what that is, please.
So technically when we talk about SIDS, what we mean is a death of an infant, and we've done an autopsy, we've done a medical record review, we've done a death scene investigation, and we don't have an answer for why that child died. And for many years, deaths that occurred while babies were sleeping were labeled SIDS. And as we've gotten smarter about death scene investigation and asking those really important questions when these kind of unfortunate events happen, we've learned that there is an explanation many times. So for example, the baby may have been in the bed with an adult or with another child and someone actually rolled over and suffocated the child. Or perhaps the baby was in their own crib, but there were blankets or stuffed animals or things that actually suffocated the baby. So those wouldn't be called SIDS. That death would be due to suffocation or strangulation. And so even though SIDS cases have gone down, some of that is because we've gotten smarter about terminology, and the number of those deaths due to other unsafe sleep factors has actually remained quite high.
Yeah, so no matter if you think that this will be good for the baby or good for me, it's probably best just to err on the side of safety and caution, obviously.
You know, that first period of new parenthood, those first few weeks and months, folks are absolutely exhausted, and I've seen new parents in clinic, and you know they're doing as good as they can just to get to clinic. Sometimes it's really tiring, and we think if I could just get a good night's sleep, and what we think, well, if the baby would just sleep through the night, and brand new babies just don't sleep that way. They, you know, 2 or 3 hours and then they're up, and part of that has to do with, you know, their little stomachs don't hold very much food, and they wake up because it's time to eat again, and that's normal. But what we think about is what's good sleep for us may not necessarily be good sleep for the baby.
Absolutely. All right. Recently, Tennessee began a new campaign. It is called the ABCs of Safe Sleep. So can you kind of walk us through that or just tell us a little bit about it, please?
Sure. So we know that many of the sleep-related infant deaths that we have are due to a very small set of risk factors, things like babies sleeping on their stomach, babies sleeping with someone else, or babies sleeping in a crib with unsafe items such as extra blankets or stuffed animals. So that ABC message really helps keep it very simple for not only for parents but other caregivers, grandparents, child care providers, anyone who's going to be involved with that baby. And the ABCs stand for babies should sleep alone, on their back, and in a crib. And it's as simple as ABC, easy for folks to remember, easy for folks to share with anybody who's going to be caring for that baby.
How do you get that message across to, let's say, grandma or grandpa? Because I know it was different, you know, when they raised their children. There weren't these guidelines, there weren't these safety measures in place. How is that convincing, how does that go for so many of them?
I'll tell you, it's really hard. And when I was a brand new pediatrician, the person I worried most about convincing was grandma, because that's who mom or dad is going to go to for advice.
That's right.
And so the way I always tried to spin that was, our medical knowledge and science is advancing all the time, and we learn new things. So, many years ago, we didn't know that kids should ride in car seats. And in fact, Tennessee was the first state in the country to have child safety seat laws. But prior to the 1970s, we didn't do that. And it was normal to ride down the street and not see kids in car seats. Right now, if we see that, we have this very visceral reaction to that's not right. And so we have that reaction because we've learned there's a safer way to do it. And so I'd like to bring that in and have that conversation with families and say, we did that before, we didn't know any better. We know better now, and so we need to change the way we behave.
That's excellent to be able to give an example of something else that's come a long way too.
Right.
It's just kind of everybody's got to be on the same page, right? What are some of the easiest practices, Dr. Warren, to minimize the risk of infant mortality?
So if we think about infant mortality broadly, we've talked about some of those safe sleep practices.
Sure.
One of the things, again, we know that prematurity and low birth weight contribute to our high infant mortality rates. We know that smoking contributes a lot to those. So we always advise people not to smoke in general, but certainly not to smoke during pregnancy. We want to make sure that moms get early prenatal care. They're connected to a medical provider. So if there is a complication with the pregnancy, or we anticipate a complication with the delivery, that can be worked on in advance and make sure that mom and baby deliver at the appropriate place. Those are some very simple things we can think about.
Yeah, the smoking is obviously something that I know that you all constantly, keep reminding moms. But what would you say to moms overall about their health? What do they need to keep in mind, as they're carrying this baby?
So one of the most important things is for women of childbearing age in general to think about how they are as healthy as they can be before they ever become pregnant. So if you've got problems with blood pressure or diabetes, or you're maybe not physically active, waiting until you get pregnant to fix those is not necessarily the best time. It's a short window, 8-9 months. And so that's not really a lot of time to reverse years of poor health. So we really want the population in general to be as healthy as they can be before they become pregnant, and that's really going to increase the chances of that pregnancy being healthy and that baby being born on time and at a healthy weight.
All right, there are some services like home visiting programs. Can you tell us about some of those things that people might not be aware of?
In all of our 95 county health departments, we've got staff who provide programs like WIC, the Supplemental Nutrition Program, that provides supplemental nutrition for pregnant women, but also infants. In all of those counties, there's also case management services, so folks who can go out and work with families in the home to be able to provide them some basic health information on baby's development, even prenatally to help mom coordinate that care, make sure she's connected with an OB, and has a source of care and a plan for when she's going to deliver.
All right, and most important key point that people can take away from today?
I'd say let's really focus on those ABCs of safe sleep. We know it's about 20% of all our infant deaths. Babies should sleep alone, on their back, and in a crib.
Absolutely. All right, Dr. Michael Warren, so nice to see you and visit with you. Thanks for the information.
Absolutely, thank you.